Indeed, I'm a pediatrician of Doctors Without Borders. The last 3 years and a half, I did multiple missions with them. Doctors Without Borders is an NGO. They mainly they do humanitarian work, and they mainly have emergency missions, so projects of rather short-term, projects of a couple of months, but they also have some development projects that work more on the long-term projects that take multiple years. And their main objective is always to provide medical care for people in need. And they work in an independent way because they're financially independent. They live from gifts from people. They don't accept money from governments or big companies, and in this way they can choose where they go and what kind of medical care they provide based on the needs and not based on any economical or political hidden agenda. What does it mean to go on a mission and to be a doctor in the tropics? It means adventure, because often places are difficult to access. You need to take different kind of transport media. It also means basic life conditions. This was the toilet for 6 months in my first mission. And this was the food during 6 months, and the food wasn't too bad, but it was just every day more or less the same plate because food was difficult to access. Of course, settings are quite different than what we are used to here. This was a hospital, so it was made of different tents. And as you can see, inside the tent it's quite decent, but still patients are quite close to each other. Sometimes chickens were running around, so hygienic circumstances were not the same as we're used to. And then this was a team with who I worked in Congo, the expat team. And we were very diverse in terms of origin, but we were also very diverse in terms of function, because if you hear Doctors Without Borders, it seems that they sent a bunch of doctors to a project to go and save lives, but the truth is very far from that. The expat team, I was the only doctor, and there was also a nurse, but besides the medical people, you also need a lot of other people. We had someone who was responsible for the supply, so who makes sure that all the materials gets in place. Someone who takes care of the logistics, so who will build the tents, who makes sure that there is transport of patients, transport of the expats. Someone takes care of water and sanitation, make sure that we have latrines, that we have clean water. Someone takes care of diplomacy, because you can imagine in conflict areas you cannot just start your project, you have big security issues, so you need someone who goes and talks with the army, with rebellion groups, with all the different actors in place to be able to set up your project. And then of course you need people who do all the paperwork, the administration, who take care of the finances, who make sure that everything is within the budget and so on. So it's really a teamwork, and you need much more than just doctors. And then there is another thing that is often forgotten, that's that only 5 to 10% of the people who work in project of Doctors Without Borders are expats. Most of the people, 95%, are the national staff, the people from the country and from the region. And these two pictures are the teams in Congo and Sierra Leone with whom I worked. These are doctors and nurses, but of course also the logistic team. There are people who work with them in the administrative team, in the supply team. So really a lot of people from the country itself. Doctors Without Borders will foresee medical care for the people in need, but they also try to make it sustainable, to make it a lasting difference. Even in the projects that are just for a couple of months, and this is done by organizing teaching. So in this first picture, we organized some classes in neonatal life support for midwives and doctors, and also by bedside teaching. Now I'm going to present you 3 cases from the field. Those were 3 children that arrived in this project. This was a malnutrition project. So in this area, Doctors Without Borders was supporting different health centers. And then most of the children were treated in an ambulant way. But the children that were too sick were brought to the hospital. And in this hospital, diagnosis was mainly done based on history taking and clinical examination. We had some point-of-care tests, like an HB and a glycemia, and we had some rapid tests for malaria and HIV, but that was it. Therapy, we had the essential drugs, which are some antibiotics, antimalarials, IV fluids, and so on. This is the first child. It's a 3-year-old boy who had, since a couple of days, fever and altered consciousness. The parents went to another hospital, but the child couldn't be treated there because they didn't have enough money. So when he came to us, he was actually in quite a bad condition. He was in a coma. He was only responsive to pain. This picture is taken a couple of days later, but you can still see that he has a central facial palsy and hemiplegia. Malaria rapid test was positive. This was a malaria endemic region, so most of the children were positive. HB, AIDS, which is quite okay for a malaria endemic region. Often children have lower HBs. And he was hypoglycemic. Now, if you're in the tropics and you have a child with fever and a neurological deficit, the first that comes into your mind is cerebral malaria, and as a differential diagnosis, meningoencephalitis. And those are also the treatable causes, so that's what we treated. Of course, we gave him also glucose. We treated with antimalarials, IV, and antibiotics. And we gave IV fluids. We didn't give acyclovir because we didn't have this. Second case is a 2-year-old boy who came with his mother to the project, and she said, actually, since a year he's sick. He's always sick. He doesn't eat. They went multiple times to the health center. He got some paracetamol, malaria was treated a couple of times, but she said, this child is not improving. When we did a bit more of history taking, it turned out that she was not a biological mother. She was actually the aunt, and his mother died before of an unknown disease, and actually also his father, and also his 2 siblings. The child was severely malnourished, had also an extended tinea capitis, and a malaria test was positive. And of course, with this history, you want to exclude HIV, and unfortunately, we couldn't exclude. It was 2 different rapid tests were positive, and this was sufficient to make the diagnosis of HIV. So we started this child on antiretrovirals, we started a renutrition therapy, and we treated his malaria. Third case is a 12-year-old girl. She came with her grandmother. Also, both her parents had passed away. And 6 weeks earlier, she had a little accident. She was cooking, and some water was spilled on her leg, and she had a burn wound. At that point, her grandmother was on the field working, and she was taking care of her siblings. They went to the health center. They treated it with some traditional plants. But then further on, the wound wasn't healing. It was actually getting worse. The grandmother wanted to go back with her to the health center, but it was quite far away. The road was also very muddy, so actually she didn't go back. And now she was very worried. She came to us because the child was losing weight. She became very apathic. She had a fever. She was not going well. And her skin looked like this. And these are not the burn wounds. The burn wound was on her leg. These are wounds caused by severe malnutrition. Child has also malaria positive. We started this child on renutrition therapy, antimalarials, antibiotics because the wound was infected, and wound care. 2 weeks later, no improvement. She was still on the same weight. The wound was not really improving. The skin was still full of lesions. And if you are in the tropics, in a TB endemic area, and a child is not improving under renutrition therapy, you always have to think about TB, even if the child is not having respiratory symptoms. And moreover, here the grandmother was coughing quite a lot. So we suspected TB. We couldn't investigate this. We didn't have anything to prove it, but we started empirically TB treatment for her and her grandmother. Now I presented 3 cases, interesting from a medical point of view. And this is the usual way we look at patients. We have symptoms, we have a clinical examination, we make a diagnosis and a treatment. But let's now look a bit in a different way to these cases. Like, let's wonder what would have happened if circumstances would have been different. Like these 3 cases, these 3 children came quite late. They were already very sick. And actually they tried to get help earlier on. The first child wasn't helped because they didn't have money. So imagine that their access to healthcare would have been easier, that this child, that care for this child would have been free of charge, or that they would have had social security so they could access it more easily. The girl of the 12-year-old girl, she went once to the health center, but the second time was difficult because roads were very bad. Like, imagine that roads would have been better. And imagine that what if the quality of care would have been better, because the girl went to the health center, but they didn't take care well. They didn't treat her wound very well. The boy in the middle, he went multiple times to the health care center, but the diagnosis of HIV was never made, and he was never treated in a correct way. The last 2 children didn't have parents anymore. Their mother died, and we know that when a child doesn't have a mother anymore, the chances of morbidity and mortality will increase. And actually, you could also say, like, what if these mothers would have had better quality of care? Then the mother of the boy would have had a diagnosis of HIV, she would have been treated, and she would probably still have been alive. And also this girl, the 12-year-old girl, she lost her mother because when she gave birth to her little brother. So this is also something we can difficult imagine here, that mothers still die when they deliver. What if these children would have had better houses? What if these children would have had mosquito nets? Then probably they wouldn't have had malaria. What if hygienic circumstances would have been better? Then probably this girl, her wound wouldn't have been infected. What if they would have had sufficient and qualitative food? They probably wouldn't have been malnourished. What if these children wouldn't have lived in an area where TB and HIV is endemic, and these diseases are linked to poor areas? What if these children wouldn't have poor? And probably if these children wouldn't have been in these conditions, they wouldn't have been sick, or at least they wouldn't have arrived in this very bad condition. And that's when we talk about the social determinants, the circumstances that determine health, actually. And you might say, yeah, we can actually also do this exercise for people here, and of course, you can also do this exercise for people here, but let's say that in the humanitarian projects, it's just even more clear. These were 3 examples, but actually we could use exercise for every patient we saw in the project. If you would make roads better, if you would make medicine free of charge, if you would improve the quality of care, if they would have better food, better hygienic circumstances, and their mothers would be still alive, probably most of the children would never have to come to the hospital. He started to increase his weight, and he became a very playful and happy little boy. This girl, for her, it took a bit longer. As I said, the first 2 weeks she wasn't improving, but then when we started tuberculostatics, she started to improve, and her skin started to heal, the wound started to heal. And 2 months later, and 11 kg later, she turned into this lovely girl. But unfortunately, it's not always ending this well. This picture is a 2-year-old girl who arrived in septic. She was malnourished. She had a pneumonia, and yeah, we started treatment, but it was just too late. And for her, you could do the same exercise. What if? What if she would have been well vaccinated? What if she would have been well fed? What if quality of care in the health center would have been better? What if the roads wouldn't have been so bad because people took them a day to get in the hospital because they had to go by foot on difficult roads? If we translate these cases into numbers, then we see that still every year 5.2 million under the age of 5 die worldwide. The countries with the darker color are the countries where child mortality is the highest. In the darkest countries, more than 1 in 10 children will not reach the age of 5. If we then look to the causes why they die, then the number 1 cause is 16% are complications due to preterm births. Number 2, pneumonia, and number 3, diarrhea. Malaria is also an important one, 5%, but of course you don't have everywhere in the world malaria. So in some countries this will be a more important cause. And in 45% of the cases, malnutrition is underlying. So if you now look at these causes, malnutrition is easy to prevent. You just have to make sure that children get good, sufficient and qualitative food. If you look at pneumonia, it's quite easy to prevent. You have to just make sure that you vaccinate the children against pneumococcus and Haemophilus influenza type B. And then once they get pneumonia, if you are in time with your antibiotics and you have oxygen, which is not very expensive, if you do it in time, children will not die of it. Diarrhea, same thing. You can easily prevent it by providing good water and sanitation. And once children get diarrhea, you can prevent they die of it by making sure they stay well hydrated. Preterm birth, you may say that's maybe more difficult, but actually when you do a good basic prenatal follow-up, you will have less babies that are born preterm. And once preterm babies are born, you might say, they need intensive care and everything. Small part will need it, but the largest part just needs warmth and regular feeding so they don't have hypoglycemia, and hygienic circumstances so they don't get sick. So actually, the reasons why all these children die are quite stupid, actually. These diseases are simple. We know how to treat, we know how to prevent, and still they die of it. So why? Because of the social determinants, because of the conditions where they live in. So I started the presentation with being a doctor in tropics, a lesson in humility. The conclusions that will follow, you can also draw these conclusions when you work here, but again, in the humanitarian world, they're just more pronounced. And the first thing is being humble towards your individual impact. As I said, just by going there as a doctor, you will not save lives. You need a whole team to make it happen. And actually, that's the same here. A hospital is actually one big teamwork. The second point is being humble towards the position as a doctor, the position of medicine. Because as we just saw, most children die of simple diseases. We know how to treat them. And the reason they die is because of the circumstances that will determine health. And so how can we actually save a lot of lives? Well, that will be by changing things on political level, on economical level. And of course, we have our role and we have our position, but it's good to always keep in mind the broader picture and to not go too much in tunnel vision, because in medicine we are often disease, diagnosis, therapy, but it's always good, I think, to keep an open mind and to have the broader picture in mind. And then the last point is be humble towards your patients, because a patient is a human, and I think every human has an equal right to have a happy and healthy life. And I think we should remember ourselves all the time about that, to stay motivated and to try to make lives better. Voilà. Thank you, and I wish you good luck with your careers.